help folks who are dealing with an MS diagnosis isn't touching this case at all. But yet we're seeing here, they're like, oh, there's actually not that much of a demyelination picture going on an antibody level. So isn't that interesting that we're, on paper at least, actually doing a pretty good job, but unfortunately clinically it's not translating into a clinical benefit. So that suggests to me that we're missing something, that there's something else going on. And coming up, we'll see that that may very well be the case with this patient. So moving on to the next section here, I'm looking at the blood-brain barrier disruption. So again, nothing too crazy with the numbers, nothing in the red zone, like nothing above 20. And also, actually, circling back here, also, in my opinion, really encouraging to see that there aren't any of these IgM antibodies coming up. As a quick reminder from the last video, the IgG antibodies plus IgA, those are the longer term antibody response. The IgM is the a more acute antibody response. I recently came up with an analogy I was using with the patient to explain this, and I think it's a good one. So I'm going to throw it out there, and we'll see what you folks think. Hopefully it lands. So when the immune system is encountering something that it needs to respond to, then the IgM antibodies are kind of like the paramedics and the emergency room doctors. So a person's having a heart attack. It's like, oh, call the paramedics. Okay, try to get the person stabilized. Get them on a defibrillator. Put some like clot busters in their veins. Get them to the emergency department. Do whatever needs to be done in the emergency department to stabilize the patient. Maybe do like some emergency surgery. And then after all that's done, after all the acute stuff is done, then they're going to move to the rehab. They're going to be, monitored for a little while. They're going to start doing some rehab. They're going to, their healing journey, their longer term healing journey is going to take, weeks and months after that. So the IgM antibodies are kind of like the first on the scene antibodies, like the paramedics and the, say, emergency room doctors. The IgG antibody response is going to be that longer term like rehab. So that's the doctors and caregivers in the ICU and then in the rehab center, etc. So what's good to see here is that the IgM levels are totally normal. They're all under 10, which is wonderful. And that suggests that there's not this kind of ongoing there's not some trigger that's triggering the immune system on a day-to-day basis. It looks like this is more of a things are in more of like kind of a long-term management mode as opposed to like a more acute mode. If we see a lot of IgM antibodies, it suggests that there's maybe a toxin or there is some a microbe or like some type of a trigger that is irritating the, say, nervous system in this case in real time. The IgG tells us like, okay, the kind of the fire was set a while ago and it's it's burning at a certain rate, but there's not like active fire setting happening, like ongoing additional fire setting happening. So in my opinion, to my understanding, the IgM being normal looks really good, and it just further suggests that we're actually doing quite a good job keeping the keeping the immune system as happy as possible, at least in this context. So good to see the IgMs looking good. And so down here in the blood-brain barrier disruption section, same thing, IgMs are looking good, seeing some elevation of these IgGs. And let me see if there's anything else here. Yeah, and that's it. For the blood-brain barrier disruption, I think there's five-ish antibodies to look at, so only 2 out of the 5 or so, not terribly highly elevated. So it'd be nice to see those, down below 10, but not looking too bad. So still likely not explaining why we're seeing these really challenging symptoms that aren't responding. Peripheral neuropathy section. So this patient does have some peripheral neuropathy symptoms. We can see here that the IgM is quite highly elevated. It's above 20, so it's in the red zone, the eyebrow raising zone, and it's also IgM. So this helps to let us know that there does seem to be something that's directly affecting the nerves, and that would make a lot of sense given the magnitude of symptoms that this patient is experiencing. There's quite a lot of pain. Now, it could very well be that it's partially related to the fact that there are these like terrible muscle spasms happening associated with a lot of pain. They're happening multiple times through the day, happening through the night. And it could very well be that it's that just kind of recurring pressure, that recurring like strangulation that's happening on those peripheral nerves that's creating these antibodies. When we look at the actual write-up here, when we see these elevated anti-GM2 antibodies, can be characterized by tingling, numbness, loss of sensation in the arms and legs, burning sensation in the feet or hands, and sharp stabbing pains. So the patient certainly has, some of those symptoms. But when we look at like what the anti-GM2 antibodies are associated with, they're associated with neurological conditions like chronic motor neuropathy, which patient probably doesn't have given the nature of their history. ALS, patient doesn't have that. It's just their history doesn't support that. Chronic demyelinating neuropathy, maybe. Demyelinating Guillain-Barré syndrome, which definitely doesn't have a history of Guillain-Barré syndrome. And so it's, and then, that's kind of like the DDX list for that. So that doesn't really explain what's going on. Again, could be related to chronic demyelinating neuropathy because the patient has MS. So there is a demyelinating syndrome. So that could very well be explaining what's going on. With that being said, where we're seeing so much, like where we're seeing the demyelination section, like the earlier section, kind of the more the central nervous system, not the peripheral nervous system section, showing the demyelination profile looks quite good. I'm wondering if it's more of like a mechanical thing related to those muscle spasms, etc. Regardless, the plan moving forward for this patient is to work on a much more robust immunomodulating protocol. Patient's hopefully going to be starting on some stronger pharmaceutical immunosuppressive type treatment to try to like get a handle on things. And there's a couple of other irons that we have in the fire. So anyways, that being said, with the peripheral neuropathy section, there's about, again, like 6 or 7 different peripheral antibody different peripheral neuropathy antibodies that are tested, and this is the only one that came up, but it did come up quite severely, and one is enough. You can have notable symptoms with just one. Just for nomenclature purposes, when we talk about the peripheral nerves, so peripheral nerves are all the nerves that branch out of the spinal cord. So we have our brains, of course, which are collections of nerves. The brain's attached to the spinal cord, which of course runs through the vertebral column. So brain plus spinal cord is the central nervous system. All the nerves that branch out of the spinal cord to all of our our arms, legs, fingers, toes, all of our organs, etc. Those are all part of the peripheral nervous system. So that's the differentiation there. So where things get quite interesting with this case is that we see in the neuromuscular disorder section, there are these anti-voltage gated potassium channels that, again, are IgM in the red zone. And so this is where I got quite clinically excited to see this because I feel like it gives us an insight into why this patient has not responded to treatment up to this point and where we're maybe really missing something. So if we look at the write-up here, so these voltage-gated potassium channels are membrane signaling proteins that help in various physiological processes. They help in nerve impulse transmission, so that's a big problem challenge in MS, and are also important for the release of neurotransmitters and hormones. Antibodies to the VGKC complexes are seen to be associated with varying conditions like limbic encephalitis, which is inflammation of the limbic system, which is the emotional region of the brain, including structures like the hippocampus, hypothalamus, amygdala, and thalamus. It can be accompanied by anxiety, depression, irritability, mental confusion, and hallucinations, which this patient thankfully does. I mean, it's going through a lot. So as you might imagine, maybe sure there are some mood challenges and some anxious components, but this patient is actually, very, very, even keel, calm, cool, collected, like just very, very, very stoic in the face of everything that they've been going through for the last number of years. And they certainly don't have any signs of mental confusion, hallucinations, things like that. So that does not fit the picture. But then, as it says here, the VGKC antibodies are also associated with acquired neuromyotonia, which is characterized by muscle stiffness, abnormal muscle contractions, cramps, delayed muscle relaxation, and increased sweating. So this patient, to my recollection, does not have increased sweating, but has all that other stuff. So that's where I got quite, again, clinically excited that like, oh, this is, in the red zone. This is really notable. It's the IgM antibodies in the red zone, and it directly correlates with the symptoms that this patient is dealing with. I feel like the proof will be in the pudding. We'll have to see how things progress with this case. We'll see if the treatment, sort of the pivot in treatment, leads to an improvement in how the patient's doing. But I feel like the insight that we got from doing this test, like for that, those anti-voltage gated potassium channel antibodies, that information alone, I think was very, very valuable. So this, as I've indicated already, there's a few applications of the NeuroZoomer Plus test for patients with neurodegenerative conditions. One is to monitor, how are we doing? Patients doing really well. Are we missing anything? Let's do a check-in with a NeuroZoomer Plus. Patients aren't going to go for MRIs, every 3 months to check in on things. MRIs, if they progress one way or the other, they tend to do that slowly.